Hello, welcome to Neobiotech International Virtual Seminar. Thank you for sharing your moment with us, and I wish everyone is healthy and safe. My name is Chi Hun Shin, a host for tonight's session. Weekly online seminar from Neobiotech will be as you see on the screen. For any inquiry, please contact your local sales representatives for details and registration. As a lecturer, Dr. Loreti Paolo from Italy is with us to speak about if it is possible to match guided surgery and bone reconstructive surgery for an hour and share his experience and knowledge. Please use chat button to communicate with me about any issues other than the topic. We'll have Q&A session after the lecture, so please submit your questions through Q&A button. Speaker may not answer for all questions because we have limited time to take all questions. If you have more questions or anything for discussion, you can contact Neobiotech website, Facebook page, or via email. Okay, now let's have Dr. Paolo to start. Please welcome Dr. Paolo. Hello, doctor. How are you doing tonight?
Welcome to everybody, and thank to Neobiotech staff for this invitation in these international seminars. I will speak about guided surgery and how to perform it in severe bone hypoplasia cases. Well, I'm Paolo Loreti. I'm a maxillofacial surgeon and a dentist. I'm the chief of the maxillofacial department in Humanitas Mater Domini Hospital in Milano. Well, I will speak about guided surgery. First of all, what is guided surgery? Guided surgery approach is make implant insertion easy and predictable. Guided surgery planning allows virtual choice of length and diameter of implants and their correct position related to prosthetic plan. Another advantages of guided surgery, it has a low morbidity because it is possible to perform it flapless. And in the most cases, it allows immediate loading. But guided surgery can be used when you have a bone and soft tissue hypoplasia. I have used a lot of devices in my job about guided surgery. I started with Nobel Biocare. I used expertise from Dentsply. I used Straumann guided surgery. And then I used NaviGuide, the first Neobiotech device for guided surgery. And nowadays I use NeoNaviGuide. Why I use Neobiotech? Because I like a lot the IS2 active implant. It is a very good implant in my opinion. It permits fast osseointegration, have a strong primary stability. And first of all, it has a perfect prosthetic solution. So guided surgery with IS2 implant was a natural development. This is a kit of Neobiotech, NeoNaviGuide kit. This is a very good kit, very easy to use, very handleable. So, start about talking about guided surgery. Guided surgery is a surgery that is performed through a specific surgical template. With this particular device, it is possible flapless fixture insertion. And Often it permits immediate loading. In this slide, you can see on the bottom of your left side, there is a radiographic guide, then the surgical template on the top on the right, and then on the bottom, the prosthetic solution. Guided surgery has a lot of advantages. First of all, it has a low morbidity in respect to traditional surgery. If you have to perform a full month of rehabilitation with guided surgery, it is a flapless surgery, and you have low discomfort for the patient in relation to a traditional surgery where you have to skeletonize or the maxilla or the mandible. Another great advantages of guided surgery is that it is possible with this approach to put the implant in the exact position that you have planned with your prosthetic plan. Not always it is possible with traditional surgery, also in cases of very expert surgeon. So guided surgery, with guided surgery, it is possible to put the implant in a very static position related to the prosthetic plan. There is a particular flow chart in guided surgery. First of all, I speak about, first of all, of the full mouth rehabilitation. First of all, there is a planning. For planning, it's important the surgeon knows exactly what are the passages of for a correct prosthetic rehabilitation. From the prosthetic planning, there is derives the surgery and then the final prosthesis. The laboratory is also very important in correct realization of guided surgery. The laboratory flow chart is the laboratory must produce the scan template that is that you can see on the bottom left of the screen. From the scan template, the laboratory can produce a provisional prosthetic makeover and a final prosthetic makeover. Another very important part that in the flowchart is the occlusal index. Occlusal index is extremely important, first of all, when you perform a full arch rehabilitation. Occlusal index allows the separation between the two jaws. And it is extremely useful when you made a CT scan to the patient. It permits to not to have a superposition between the radiological guide and the jaw antagonist opposite jaws. There are two types of TC scan: a spiral CT scan, that is a classical hospital TC, and a cone beam TC scan, that is the TC that is that you can find in dentistry office. All of them are okay for guided surgery, but if you have cases where the bone is not so good to represent, I think it's better spiral TC because it is more precise. From the CT scan, it is possible to have the DICOM files. The CT scan produces DICOM files. These are the files related to the bone part of the jaws of the patient. These DICOM files are uploaded in a specific software. Together with the DICOM files, in the software must be uploaded the STL files related to the prosthetic planification. From the treatment plan, you or your laboratory can produce, or a production center can produce the surgical guide. There are various types of surgical guide. I will speak about it next. It is possible to use intraoral scanning if you want to bring the relief of the patient. One device is this. Medit is a good device, but intraoral scanning at the moment is useful only in partial denture cases, not in dental cases at the moment. And it's necessary to convert the scan file into STL files to match them with the DICOM files, the radiographic files, into the planning software. What skills are necessary for a surgeon to perform a guide surgery? First of all, the most important skills is prosthetic skills. First of all, if you have to plan a full mouth rehabilitation. Secondly, surgical skill. Surgical skill, and it's not so important in guided surgery because it's from the surgical point of view, it's an easy surgery. And another important skill is software planning skills. This is the first and the third is the most important steps. Which software can be used? There are a lot of software for planning guided surgery. In Italy, a lot of clinicians, me too, use a Real Guide from a 3DM company. It's a good software, and in Real Guide, it is uploaded the STL files related to the Neobiotech implants. So it is possible to use it for your guided surgery planification with Neobiotech implants. With the files, the planification, it is possible to have a bone 3D model of the jaws you have to treat. It is possible to have a soft tissue reconstruction. It is very, very important. And it is possible to match the bone and the soft tissue with the STL files of your prosthetic radiographic guides that is produced from your prosthetic plan. So in this moment, you have all the information to perform your planning. It is possible to select the implants, the diameter of the implants, the length of the implants, the type of the implants, the position of the implants. One time you have made your planning, it is possible to plan and to produce a surgical template and then to perform your surgery. There are a lot of types of surgical template. Simplifying it a lot, it is possible to tell you that in partial denture cases, you can have a surgical template like the one you can see on the left of the screen, and this type of surgical template can put directly on the remaining dentures. So don't need to have other device for stabilization. If you have to treat an entire jaw, the surgical template must fix to the mandible or to the maxilla with some pins. You can use pins like this, or you can use osteosynthesis screw. You can fix the surgical template in vestibular position or in palatal position. It depends from the preference of the surgeon. The most important thing is the surgical template fit perfectly on the maxilla or the mandible. If it doesn't fit perfectly, you introduce an error in your surgery. Temporary prosthesis, how to build it. Temporary prosthesis manufactured from the surgical template, the laboratory can build a primary model with implant replicas. These primary models is put in the articulator with the surgical template and the occlusal index. And in this manner, it is possible to relate the jaw where you have to perform the guided surgery with the opposite jaw. So the technician have all the information to build the temporary prosthesis dentures. The temporary, on the model, the technician built the temporary abutments, and on the temporary abutment can build the temporary prosthesis. In these cases, only teeth-bearing prosthesis. There are two types of temporary prosthesis. One type, only teeth-bearing. You can see an example of this on the top of the screen. And a second type, a Toronto temporary prosthesis. What's the difference? In the first case, you have teeth emerging directly from the soft tissue of the patient. And in these cases, obviously, you have no bone resorption and no soft tissue resorption. But if you have a hypoplasia of the bone, you can reconstruct the bone, or you can use a temporary prosthesis like a Toronto. Toronto is an hybrid prosthesis which with a gum, a prosthetic gum, to simulate the loss of bone and soft tissue. Clinical examples that you can perform with guided surgery. You can perform an all-on-4 guided surgery in the case that you have a pneumatization of the distal portion of the maxilla or of the mandible. You can put a tilted implant, and the tilted implant could be put in the maxilla with a guided surgery approach, obviously. This is an example. You can see in these cases there was a final prosthesis with a gum prosthesis. It is a Toronto bridge prosthesis. Or you can have a partial prosthesis guided surgery, like these examples, where you have an dentulism only in one hemimaxilla, and you can treat obviously with guided surgery. This is the cases, and this is only bearing teeth prosthesis. Or you can perform a null-in-6 guided surgery. This is an example, the case of the presentation after the teeth extraction, the prosthetic project. From the prosthetic project, we have made a radiographic guide from a radiographic guide and occlusal index, is it possible to have a CT scan and a plan of the maxilla? You can see at the bottom of the screen the bone reconstruction, the gum reconstruction, and the prosthetic simulation with the implants in the correct position. In this case, you will see the temporary prosthesis. I can show you that the insertion of the implants is in a non-static position of the teeth. It is a big advantage that the guided surgery give to you and to your patient, the aesthetic. If you put 6 implants in traditional surgery, is it possible that the emergence, the prosthetic emergency of the implant will be in an aesthetic part of the teeth? Using guided surgery, these don't happen. So guided surgery permits a better aesthetic results. After I use to finalize the cases with cobalt chrome CAD/CAM prosthesis. This is the proof of the structure, and there is the final CAD/CAD ceramic prosthesis in situ. In this case, obviously, there was no bone tissue loss. It is possible to perform guided surgery in bimaxillary cases like this. The case is the presentation, the bimaxillary guide, radiographic guide, the images related to the surgical execution, and the final bimaxillary all in 6 temporary prosthesis in situ. The cobalt chrome CAD/CAM final prosthesis bimaxillary, and the final CAD/CAM ceramic prosthetic bimaxillary in situ. Also in these cases, you can see how the emergency of the implants are in a non-static part of the dentures. This is the case as the presentation, the panoramic X-ray after immediate loading, and the final X-rays after the final prosthesis in situ. So, guided surgery, how to plan and how to do it. An example, these cases, as the presentation, I remove all the teeth, remaining teeth, and this whole implant. The prosthetic plan, you see, there is, this is a proof, a prosthetic proof that it is absolutely necessary to do, to perform, for match the aesthetic resolution of the cases, to show to you and to your patient how will be the final results. When you have done this prosthetic plan, you can perform a scan template makeover. This is a production of the radiographic guide that put in itself the prosthetic plan you have done. From this plan, your laboratory can produce a temporary denture reproduction, radiographic guide, a scan template, and occlusal index. The patient put the temporary denture reproduction, the scan template, and the occlusal index in his mouth, and the CT scan is performed. From the CT scan, you can have the DICOM file, and you can, with your software, reconstruct the bone of the patient, the reconstruction of the gum of the patients, and to perform the virtual treatment plan with your software. When you have performed the treatment plan, you can check it, and you can check if your implants are in the correct position related to the bone availability. If your stabilization pin are in the correct position, if your head of the implants are in the correct emergency related to the gum of the patient, and if your prosthetic project plan is correct with the position related to the position of the implants. You can check every single part, every single implant to check if the implant is in the bone, if there is in the correct direction related to the teeth. And you can check every single implant, and you can move, you can change the direction, you can change the diameter, you can change the length, etc. When you have ultimate your plan, you can print a checklist. Checklist is very useful for you and for your assistant when you perform the surgery. The same thing about the inferior mandible, inferior jaw, the mandible. With your software, it is possible also to produce a virtual model and a virtual surgical template. You can check the pin location. You can check the sleeve location if there is no interference with the gum or with the bone or with the implants. And when you have checked all these things and you have produced your virtual surgical guide, you can, same in the mandible, when you have produced your virtual surgical template, you or your laboratory or a printer farm can produce the real surgical guide and the occlusal index. In the surgical guide, you must insert the particular sleeves specifically related to the typology of implants you have used. This is the bimaxillary surgical guide, the occlusal guide, the temporary abutment. The temporary abutment must be cut at the correct occlusal distance. You can cut you during the surgery, or better, you can the laboratory can cut for you to simplify your treatment. The temporary prosthesis. The temporary prosthesis must fit exactly on the temporary abutment. And then the case after the immediate loading surgery. It is possible to perform in local anesthesia, without sedation, without general anesthesia, a bimaxillary guided surgery cases like this. I've done a lot of times these bimaxillary cases. And this is the final CAD-CAM prosthetic solution, the bimaxillary cases. You can see how the screw that fix the final prosthesis to the implants are in a non-aesthetic position, and so to maximize the aesthetic resolution of the cases. But how to treat our patient if we have hard and soft tissue limits? How to overcome them? If you have a bone or a gum hypoplasia. Well, I show what I do with some example. First of all, one example is posterior maxilla bone reconstruction and guided surgery. In big reconstruction, I use to reconstruct the bone with autologous bone, in the majority of cases with iliac crest bone. After 4 months from the reconstruction, I perform the guided bone surgery, like a case like this. This is the case of the presentation. The loss of the teeth in the posterior maxilla, reconstruction of the maxilla with bone harvested from iliac crest, and after 4 months, removing of the osteosynthesis screw and planning of guided surgery and guided surgery with implant in immediate loading. This is a temporary prosthesis after immediate loading surgery, and the final prosthesis with CAD-CAM chrome cobalt final prosthesis. The final prosthesis in situ, and the patient smile. Guided surgery after maxillary reconstruction with calvary harvesting bone. In severe bone hypoplasia, is it possible to use reconstruction with calvarial bone? Obviously in general anesthesia. And it is possible to perform guided surgery not with a flapless approach, but with an open approach. So you have you can remove in the same surgical time the osteosynthesis screw and put your your surgical guide directly on the bone and insert the implants with your planning. In these cases, the advantage is to make only one surgery, a surgery with removal of the osteosynthesis screw and with immediate loading. Guided surgery is possible after maxillary reconstruction with hip harvesting bone. Case like this, I remove the teeth, I reconstruct all the maxilla with bone harvesting from iliac crest. Then, after 4 months, I remove the osteosynthesis screw. I let the gum tissue to heal, and then I plan the guided surgery with the flapless approach. This is the planning, visual in 6 guided surgery. This is a temporary prosthesis with immediate loading. Chrome cobalt final prosthesis, and the final ceramic CAD-CAM prosthesis in situ. Guided surgery can be performed also after bimaxillary reconstruction with hip harvesting bone. Case like this, we have a severe bone hypoplasia in the maxilla and the mandible. I reconstruct with bone harvesting, hip harvesting bone the maxilla with inlay, onlay, veneer graft, and the mandible with osteotomy, sandwich visors, osteotomy, interpositional grafting. After 4 months, I remove the osteosynthesis screw. I let to heal the gum tissues, and then I plan the bimaxillary guided surgery. In the maxilla, I perform a all-in-6 guided surgery. In the mandible, I perform a all-in-4 guided surgery. This is the final cases with CAD-CAM total ceramic prosthesis in the jaw, in upper jaw and lower jaws. Other cases with reconstruction of the maxilla with iliac bone, and like the case you have seen with scalvaral bone, it is possible to perform a guided surgery with a guide directly on the bone of the patient to have only one surgery. In this surgery, you have to remove the osteosynthesis screw and to put directly the implant with immediate loading, the final prosthesis in situ, with the bone and the gum reconstructed. Nowadays, there is a time for zygomatic fixture. You can use zygomatic fixture instead of reconstruction of the maxilla. You can put in hybrid cases, you can put the anterior and the inferior implants with guided surgery, and you can put the zygomatic implant with open approach. I don't use guided surgery at the moment with zygomatic implants because at the moment it's not so easy, not so easy to do zygomatic with the guided surgery. So I can put the normal implants with guided surgery and the zygomatic with open approach. This is the case for all of us who are interested in zygomatic implant. You can show in these images how the head of the zygomatic is not in the palatinal position, but is near the crest. This is the new approach, the ZAG approach for zygomatic implants. And it is possible in particular cases to use guided surgery with orthognathic surgery and reconstructive surgery. An example, this patient who have open bite, skeletal open bite with a third class position of the two jaws and extremely periodontosic problem. I have made this extraction of all the teeth, and the relationship of the two jaws was in third class. I've made a bisagittal split osteotomy setback of the mandible and the reconstruction of the total maxilla with iliac crest bone. After remove of the osteosynthesis screw and healing of the soft tissue, I have made my plan with bimaxillary guided surgery, and then I've performed a bimaxillary immediate loading guided surgery of the case. This is the X-rays, the posterior-anterior, the lateral, and the OPT of these cases, and the final prosthesis in situ. Okay, thank you for your attention, and I give to Chi the talk for your eventually questions. Thank you for your attention. Okay.
Thank you, Dr. Loreti.
Okay.
And can you stop sharing your screen so I can share my screen?
Okay. Okay. You hear me?
Yes. All right. Thank you very much for the lecture, Dr. Paolo. And we are very happy to take your opinion on today's webinar. Please share a minute for us, and there will be an extra popped-up screen with only 5 questions. Thank you very much for your participation. We'll always try the best to improve the quality of your webinar for your satisfaction. This lecture will be uploaded in our webinar with YouTube video, so you can watch again this lecture later at any time. Please stay connected with Neobiotech social media to communicate with us more. Search Neobiotech on Facebook and YouTube, then do like, subscribe to get more information. For the next upcoming webinar, it will be on 9th September, next Wednesday. Dr. Ricardo Arvis from Portugal will give us a lecture. Title is Current Approaches for Peri-Implantitis Treatments in English. If you have any questions or information needed, please contact us by email address. And do not forget that you can get more information in our website and our social network service. Thank you for attending our webinar. We hope all of you enjoyed this time. Please have a good day or good night. See all of you again sooner. And I'll leave this page open for you to finish up the survey. Thank you very much.